Welcome to ANA Investigates, a podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. This is a special episode of ANA Investigates on how neurology departments can recover from COVID-19. The scope and speed of the coronavirus pandemic are unprecedented in modern times. Our healthcare systems and society as a whole were unprepared for such a rapid and complete shutdown, and all areas of healthcare have been affected, including clinical practice, research, and education, with serious fiscal consequences. Many institutions have developed record deficits in record time. So the question now becomes, where do we go from here? What is our near-term strategy, and how might this change the future of academic medicine? Our interview today was conducted by Dr. Clifton Gooch, professor and chair of neurology at the University of South Florida Morsani College of Medicine and president of the Association of University Professors of Neurology, or AUPN. He spoke to Dr. Justin McArthur, professor and chair of neurology at Johns Hopkins University. Dr. McArthur specializes in neuroinfectious disease and neuroimmunology, and he is the president of the American Neurological Association. This episode is brought to you by ANA Investigates in partnership with the AUPN. Here's Dr. Gooch.
Welcome, everyone, to this special edition of ANA Investigates in partnership with the Association of University Professors of Neurology. And welcome to you, Dr. McArthur.
Thank you, Cliff. It's a pleasure to be here.
Thank you for joining us. So first, I would like to ask about the area of perhaps the greatest immediate impact, and that is on our clinical mission in academic medical centers. And I'll just comment a little bit on what we're doing, and then, Justin, if you could talk a bit about perhaps what is going on at Hopkins. We did resume clinical activity, but our clinical activity has been restricted to 30% of maximum capacity. And then the plan is ultimately to begin to gradually increase in-person patient visits as time goes on, though we are still making maximal use of telehealth everywhere we can. What's going on at Hopkins?
We have had a very interesting, from an epidemiological point of view, a very interesting shape to the curve, in the sense that hospitalized patients in our health system, and we have 5 hospitals in the Baltimore, Washington area, has basically been flat for the last 2.5 weeks. We've had anywhere between 260 and 300 patients hospitalized with COVID-19 across our health system. Second is that we're beginning to see some very important clusters of infection in the Latino population here in Baltimore, and also in several large skilled nursing facilities. And modeling, which has been done through our School of Public Health here and the Center for Disaster Preparedness, really paints a very unnerving picture for the next few months here in Maryland, because we're anticipating, as social distancing becomes relaxed, that there will be a secondary surge in July, August, and September, with an even greater surge if the schools were to open, as we expect them to in September. So we are a long way from really seeing a substantial decline in hospitalizations here. And that means that our institutional leadership and our governor, in fact, have been really quite conservative at allowing resumption of clinical activities. So we're allowed to have urgent ambulatory visits for patients who need neurological assessments, or urgent lumbar punctures, urgent EMGs or EEGs. But essentially, we're really very limited in the amount of work that we can do in person. I work with a lot of people who have MS, obviously, and we were uncertain initially whether we should continue infusions for disease-modifying therapy for MS. And as a center, we've really taken the stance that for drugs that can be deferred, like ocrelizumab, we have deferred them for a few weeks until things stabilize. For drugs that really cannot be deferred, like Tysabri, because of the potential for rebound, we've continued to use them.
And our ability to see patients is contingent upon the changing landscape of how we're tracking infection, how we're able to screen for it. So in terms of your screening procedures, here we are questioning every patient, every person who comes in at the door. We're trying to have patients themselves only come in and not family members. And of course, everybody's using personal protective equipment. Are you also doing similar things along those lines?
Oh, absolutely. We're doing the same for procedures where there's high contact, and that would include things like lumbar punctures, muscle and nerve biopsies, cutaneous nerve biopsies, not EMG and EEG. We are actually doing pre-procedure COVID testing, with the molecular tests. We are anticipating, with the recent approval of the FDA antigen test, that will probably be included, perhaps on a point of care basis, but there's still some concerns about the sensitivity of that test. It's only rated at somewhere between 85 and 90% sensitive, and so that could potentially miss true infections. And we're just looking into that in terms of a validation basis.
The landscape seems to change every week in terms of the testing options we have available, and I think it's going to continue to get better and better, but it will take time. I want to turn to research now and talk a little bit first about basic research. Obviously, there at Hopkins, you have a huge basic research enterprise in the neurosciences. And could you comment a little bit about what the effects of the pandemic have been on the work itself, as well as on funds flow from grants and other sources of support in the basic science laboratory?
Well, pretty much within the first few weeks, all wet bench labs and clinical research that was non-COVID related was closed down. Individual researchers were told not to come to work in their labs. Their technicians were not allowed to come in unless they were given specific approval to, for example, keep a cell line going or a critically important animal experiment going. We've seen a plethora of COVID-related research programs, including treatment trials, including biomarker studies. One of the concerns, obviously, is how do we restart the non-COVID research? And there is a plan now over the next few weeks to allow labs to open up with great attention to social distancing. We will probably have shift work for lab workers and for the postdocs and graduate students in the labs. Obviously, they'll be wearing protective equipment. We haven't dealt with this yet, but we think if there is antigen testing, we may fall into a pattern of testing everyone once a week or that kind of periodicity.
And tell us a little bit about what's been happening with clinical research at Hopkins.
Certainly in clinical research, wherever possible, we've tried to pivot the research to do it remotely, either via telemedicine or telephone. Our IRB allows for e-consenting, which is helpful. But obviously for neurologic diseases, especially chronic neurologic diseases, including neurodegenerative diseases, a lot of the research involves biomarker specimen collection, CSF, blood, or imaging. And obviously that's not something that can be easily converted to a telemedicine visit. And so we have basically kept those cohort type studies, those longitudinal studies on hold, in part because they can't be done, and in part because of the safety of the research subjects. I'm really pleased at how the NIH has responded to this, and we had a wonderful discussion with Walter Koroshetz from NINDS, who is very reassuring about the NIH's commitment to continuing to fund research and support existing grants, both for established investigators as well as early stage investigators. So I'm really I feel very positive about the response and support that we in the academic neurological community have had from our NIH institutions.
Well, I would say that this whole experience for the United States has perhaps increased awareness in the general public and respect for the importance of medicine and the entire healthcare team in a way that I've never seen before in my lifetime. So we can only hope that will translate into continuing funding of these important missions of clinical care research and education. Well, I want to turn our attention now to something that certainly as chairs we've been dealing with and our faculty too, and that has to do with fiscal austerity measures that are being implemented I think across the board in talking to different chairs in different states, we're hearing the same kinds of things being employed. We're being asked to increase our efficiencies, of course, to increase our clinical effort, to look for ways to cut expenses. But a lot of our expenses in medicine, of course, are in salary. So many places have undertaken salary cuts that are mandatory across the board, mandatory furloughs for staff and sometimes faculty, depending upon their duties, layoffs in some more extreme cases. Here at USF, we're just now implementing an austerity package, which may include salary cuts for faculty and staff. We've avoided furloughs and layoffs to the present time. We're certainly, going gangbusters on telemedicine to try and keep revenues going there. Our surgeons are beginning to return to the OR with the easing of restrictions in Florida. What's going on at Hopkins in this regard?
Yeah, I don't think it's any different than what you've begun to experience there, and we're still, I have to say, at a relatively early stage of implementing our own austerity policy. One of the features of for our faculty who are School of Medicine employees is they're not going to have a direct reduction in their salary, but we are going to hold their 403B, their retirement contributions that are matched by the School of Medicine and the university for 1 year. So there'll be effectively a salary reduction, but it won't be seen in their take-home pay. We're also cutting pay for institutional leaders by somewhere between 10 and 20%. There'll be no merit increases this year and possibly next. Some of our faculty, particularly our surgeons, receive supplemental pay or incentive pay. That's going to be paid out this year, but we don't know what will happen next year. Next year meaning July 1st onwards. And we also have a hiring freeze both for staff and faculty unless they're working in COVID critical areas. So we're just at the point of implementing these, and I have to say that the real pain has not yet begun.
Yes, I would agree, especially with some of the dramatic deficits that we're seeing in different places around the country. I think that we've all been racking our brains about additional sources of grants and income at this time, but I'm not sure there are other sources that are substantial other than those that we have discussed. Are you aware of any other pots that we should be looking in right about now?
Well, we've taken a fairly aggressive approach at I'll use the word marketing, but it's not really marketing so much as reassuring our existing and potential new patients that we're open for business. I've done pretty regular video clips that I've sent out, and other department directors or chairs have done this as well here at Hopkins, to our patient base and our referring physician base, basically reassuring them that the hospital's safe, that we're open for business, and that we can continue to provide neurological care for people who need it. We have taken, for neurologists, a surprisingly aggressive approach to just saying yes. If somebody needs neurological care, we will provide it. We have also reached out to our donor base and done specific messaging to our donors. And just as one example, we raised money through our donor base to purchase 20 Mind Motion Go machines. These are kinetic tele-rehab machines that can be used both on the inpatient setting and at home. So we've actually delivered these to patients' homes as they've gone home from our stroke unit to allow them to continue their rehab remotely using tele-rehab. And I think this is just another example of kind of the creative approach that some of our faculty have taken.
Well, I think that's definitely the future, and I do believe that that this whole pandemic has accelerated many things, many years ahead of where they otherwise would be. And now I would like to turn to some of our longer-term future projections about what may be happening. And first, I want to come back to telehealth. You just mentioned this robotic telehealth solution for stroke patients going home, needing rehabilitation and assessment. And there are a lot of things that affect this, of course, continuing reimbursement, et cetera. So could you comment a little bit about your view of telehealth once the tidal wave of the pandemic has settled and perhaps we have a vaccine or some other treatments? what would you say telehealth will look like in 2 or 3 years?
Well, we're anticipating that telehealth, teleneurology for us, at least here at Hopkins, will continue to be a major component of how we deliver care, and we've discovered pretty rapidly. Not only do the patients love it, their families love it because they don't have to take time off work or travel to our hospital campus, but our providers love it as well. It's much more flexible. People do it in the evenings or at weekends when they can, depending on childcare or their personal situations. So number one, it's convenient both for patients and providers. Second, I think as we get better at doing telemedicine, we can actually get much more out of these visits for neuromuscular assessment, etc. It's really imperative that we find a way to convince CMS and the decision makers around reimbursement for telemedicine that this is here to stay, and it needs to be part of our health toolkit for getting the U.S. back working again. So I'm personally, and the American Neurological Association and the AAN are pushing hard to maintain that telemedicine continue to be reimbursed. And I know your organization, the AUPN, is doing the same.
Yes, absolutely. No, I believe for all the reasons you just detailed, it's really essential that this move forward, but appropriate reimbursement and a lack of excessive regulatory burden are absolutely essential for us to be able to continue to do this. I'd like to touch also on long-term impacts on clinical care. Obviously, a lot of care is being delayed. Many patients are still afraid to even go to the emergency room for things like stroke, which we've certainly seen here and many other places have seen. And that's going to have echo effects going into the future for quite some time. So could you comment a little bit about your estimate of what the impact on clinical care will be and on our patients' health going forward 2 or 3 years?
Yeah, we thought about this a lot and have modeled it in a number of different ways. The demand, or this pent-up demand, so to speak, I think is going to be more dependent on how individuals feel about coming to hospital settings where there are a large number of patients with COVID, such as ours, whether or not they still have health insurance through their employer if they're still employed. And so there are a number of other, if you will, secondary issues that I think are going to impact care demand.
I would also agree totally with that. And I think the big question mark here is how much will unemployment linger? We have these unbelievable unemployment rate currently. How long is that going to go on, and how bad will it be in the long term? And that obviously is going to affect coverage. So one final question before we go. This one perhaps even deeper gaze into the crystal ball. And that is, how long do you think it will be until academic life as we know it returns to some semblance of normal? Or are we entering an entirely new era and things are never going to look the same, and some things will be better, some things may not be so good? What are your thoughts on that?
Great question. And I think we are entering a very different era, and we've obviously been forced to do it quickly. But whether it's telemedicine or the adaptation to Zoom meetings, or as we're going to do for the American Neurological Association this year, we've had to pivot to hosting our annual meeting in October virtually this year. This will be the first year since 1945 that we haven't had an in-person American Neurological Association meeting. And I don't think this means that we're going to replace in-person or physical meetings forever, but I do think that especially our younger faculty are more used to interacting in a digital space or a digital environment, and we will probably see a lot more virtual meetings or perhaps hybrid meetings where part of the meeting is done in person and part is done virtually. So I think that is going to change academic life very substantially.
Well, this has been an outstanding discussion, and we've covered, I think, a lot of topics that are very much at the forefront of people's minds as they're dealing with all the changes that they're facing every day among our listening audience. Thank you so much for joining us here for this great conversation.
Well, thank you for the opportunity to be here, and stay safe.
You as well.
That was Dr. Clifton Gooch, professor and chair of neurology at the University of South Florida Morsani College of Medicine and president of the AUPN, speaking to Dr. Justin McArthur, professor and chair of neurology at Johns Hopkins University and president of the ANA. That's it for today's show. You can submit your ideas for future episodes of ANA Investigates by visiting myana.org and clicking on the Education tab. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us for this episode. If you're not already a member of the ANA, please visit myana.org to learn more about the benefits available to ANA members, including access to an array of educational programs and resources, like online CME courses, webinars, the ANA's journals, the Annals of Neurology and the Annals of Clinical and Translational Neurology, and more. Dr. Adeline Goss is our host. Our producers are Drs. Romer Gioccaden, Adeline Goss, Michelle Johansson, Clifton Gooch, Danny Vega, Megan Ritchie, and Jim Sigler. This is your editor, Jen Hurley. Copyright, the American Neurological Association.